So just think about it, right? You have cancer, risk of a polyp, and it can either be low risk or high risk. Yeah. If it's low risk, all the guidelines in Europe and the West suggest piecemeal endoscopic resection or an EMR because it's safe, effective, and doesn't take very long, minimal healthcare resource, patient go home the same day, right? So all these advantages of piecemeal mean that if there's not a big cancer risk, you should do that. And if it's high risk, then you should be thinking about another technique, but these are in yellow because they cost more money, the patient's going to go more risk, et cetera, et cetera. So I've said that. There's more risk on the right-hand side. So how do you make that decision? Well, you can make it with a biopsy, but we all have heard ad nauseum that biopsies don't make that decision well because they take the surface and they don't see what's underneath. So you make it with endoscopic imaging. Now, we are bad at it. All studies show that we are bad at it, and those studies are in pretty much expert cohorts. So how can we improve that? Or more importantly, what does us being bad at it do to the patient? Well, for example, and so this is part of polypectomy training, understanding endoscopic imaging, you have to impart that to the people you're training. The benefits of endoscopic imaging versus histopathology, real time, assess the whole polyp, but of course it requires expertise and it requires training. The consequences of getting it wrong, that is, if you do surgery or en-bloc endoscopic resection for a polyp at low risk of cancer, or you do piecemeal endoscopic resection for a polyp at high risk of cancer, are significant for patients. And here are the negative outcomes in red. So for the low-risk polyp that gets surgery, for example, there's a huge excess risk of morbidity, and mortality is 3%. In endoscopy, it's 0%, right? So you have given someone a risk of mortality of 3% from a treatment for something which didn't need it, like you completely over-treated the patient. And for this way round, potentially if you piecemeal resect a cancer and you don't know that and you send it to pathology, maybe you miss the piece, or maybe the patient doesn't attend surveillance with a missed piece. Firstly, and in all cases, the patient is delayed to what treatment they should have. So, they get referred 6 weeks, then they get their procedure, then maybe the pathology takes 3 weeks. So that's like at least 10 weeks they've lost of not getting the right treatment, which was potentially surgery or potentially on. They have the risks of the resection because it was totally unnecessary. So any risk, any problem that occurred in that procedure was unnecessary, and they lost the chance for an en bloc cure. So that's just an example of one, and I'll stop now. But this is totally dependent on one thing. Like, what is this dependent on? What is the ability of people to do endoscopic imaging dependent on? Well, the Japanese can do it. They can do it with sensitivities and specificities of, in the 90s. In Europe, it's 30% accuracy. Why is that? One word: